Hello everyone, my name is Rowan Harwood. I'm a geriatrician and I'm going to talk about dementia, what it is, why it's a problem for hospital physicians, and what we can do about it. Dementia is a collection of signs and symptoms caused by diseases of the brain. You see forgetfulness, loss of other mental functions such as language, recognition, purposeful action, and decision making. It lasts for more than 6 months, is progressive, is bad enough to interfere with everyday activities, and is not caused by something else, such as delirium or a brain tumour. 1/3 of us will have dementia when we die, as do 1/3 of emergency hospital admissions. Dementia causes problems and crises. It stops people doing the things they need or want to do. It leads to distress and consequent difficult behaviours. It makes decision-making difficult, makes life difficult for carers, and it makes people prone to acute illness, injury, and delirium. Hospital physicians mostly get involved when there's a crisis, often something functional or non-specific, like increased confusion or a fall, at which time it won't be clear if the problem is primarily physical, mental, or social, or more usually, a mix of all three. And our job is to work it out. If a patient has dementia, we need to diagnose it. Physicians can diagnose dementia. It means taking a thorough collateral history, doing a mental state and physical examination, cognitive testing, brain imaging, and assessment of function. If delirium is present, or if symptoms are mild, we can't always diagnose dementia with any certainty until time has passed, usually well after the person has left hospital. In 2017, a Lancet Commission report set out the prospects for dementia prevention, on the back of evidence that age-specific dementia incidence has reduced by 25% over the past 3 decades. Avoiding head injuries, controlling cardiovascular risk factors, exercise, hearing aids, education and mental stimulation, treating depression, and good diet may prevent 1/3 of cases of dementia. Physicians are clinical pharmacologists, so a word about drugs. Acetylcholinesterase inhibitors, such as donepezil, improve cognition in Alzheimer's and Lewy body dementias, but by a very small amount, 1 to 2 mini-mental state examination points on average. Antipsychotic drugs do sometimes help when there's severe distress or aggression, but the evidence of benefit is weak. They cause real problems and should only be used when all other avenues have been fully explored, a clear target symptom identified, and they're reviewed regularly for effect, adverse effect, and ongoing need. Polypharmacy must be minimized. Complicated drug regimens are often impossible to adhere to, and many common drugs have low-level anticholinergic effects which worsen cognition and may cause delirium. One of the biggest practical problems we face is dealing with distress, manifest as difficult behaviors such as aggression, shouting out, or resistance to care. A core principle is that behavior communicates unmet need. Any of us could get difficult if we felt sufficiently afraid or overwhelmed, were in pain or wanting the toilet, and were unable to communicate it. The past 40 years have changed the way we think about well-being in dementia. Part of it's about the neurology, the amnesia, the aphasia, apraxia, and disinhibition. But it's also about meeting physical and mental health needs, understanding personality, life experiences, and crucially, relationships and the way people around us respond to us. The way to avoid distress is called person-centered dementia care. We should value the person with dementia, individualize care, show empathy, seeing the perspective of the person with dementia, and use how we talk and act to respect someone's identity as a valued human adult, bringing comfort, inclusion, and occupation, whilst avoiding confrontation and humiliation. Our challenge is how to make this work in a clinic or on an acute ward. Individualizing care is about physical health, acute and chronic, and mental health, cognitive and emotional, identifying and using retained abilities, recognizing and respecting someone's history and preferences. Mental health is important because psychopathology is surprisingly common. Among acute admissions, 10 to 20% each have delusions or hallucinations. A third each are anxious, depressed, apathetic, or sleeping poorly. Often it's this that drives the difficult behaviours. There are also physical health aspects, principally for us, acute illness, injuries and fractures, but also delirium, pain, comorbidities, vision and hearing, hydration and nutrition, bladder and bowel symptoms, and medication. We should make the most of family carers. They have information you need, and you have information they need. You need them to help with decision making and discharge planning. They may or may not want to be involved in hands-on care, and they will need constantly updating. But families vary. About a third will be co-resident spouses, the rest more distant adult children and other relatives, or unrelated. Some will be in poor health themselves, or have conflicting work and domestic responsibilities. 10% of people with dementia in hospital have no identifiable relative. Many patients with dementia in hospital are in the last phase of life. 25% will be dead within 3 months, and half in a year. We need to recognise this and act accordingly, but prediction is very uncertain. People with hypoactive delirium look like they're dying, and they may or may not do so. In hospitals, we face a big clash of cultures. We use the acute medical model, but alone it's not enough. We need to think of minimizing disruption and distress, palliating symptoms, addressing function and behavior, taking calculated and agreed risks, dealing with multiple stakeholders, including families and care homes. We have to individualize, as pathways may not always work, and we need continuity with community services. A review of dementia-friendly hospital practices identified staff needing the knowledge, skills, and the authority to respond to individual patient needs. Senior staff setting a good example, staff having enough time to spend with patients, appropriate management of risk, and valuing dementia care as skilled work. It can be done. Many of you will, I'm sure, be doing much of this already. I have 3 key take-home messages. Please keep broad-minded and curious. Empathise and care. And be a good physician, because no one else will get the general medicine right. Thank you for listening, and stay well.